Thank you so much, Ken, and thank you to my guest presenters, co-presenters, and others in the room. This has been a terrific conference, and I'm delighted to be part of it. This session is divided into really two major parts. In this segment, I'm going to briefly introduce and review community health workers' roles, the community health worker, the Vermont Community Health Worker Workforce Initiative, and then at the end of my short presentation, present an overview of the nationally recognized CHW program models that are often employed in delivering CHW services. And then in the second part of the session, our two guest presenters will present their research and their programs from their respective states and programs. So next slide, please. So I'm going to just very briefly start out by quoting Abhimana from our last session. And it's a great way to start out that community health workers are part of the solution that we have been looking for many years. And right now, I'm going to give this overview, and then I'll shift to the Vermont scene. Community health worker programs have long been heralded as a best practice for reducing health disparities and reflect the core tenets of health equity interventions. We've heard about this all day today. As they are valuable key members of the public health workforce, and they are essential frontline public health workers that work in both clinical and community settings. They are deserving of the recognition that they are essential workers and also are trusted members of their community with shared lived experience, language, and cultural knowledge. This is one area that makes them unique, and that as trusted members of the community, they can connect with individuals in a different way that others are unable to do. They share that socioeconomic status, the cultural affinity, and other identity with their clients. And that gives them a unique, intimate working knowledge of resources in their communities. They are a resource for their communities, by the way. It also allows them to understand the unique challenges community members face in preserving their health, and their relationships are based on shared power, working towards solutions that address medical issues and the social drivers of health. I want to give an example that the National Association of Community Health Workers Executive Director, Denise Smith, is a woman of color, and she has experiences with socioeconomic hardship, and also as a former community health worker is struggling with a chronic disease and has overcome oppression, racial inequalities, and other challenges in her work as a CHW. Next slide, please. So very quickly, I'm not going to go through all of these, but the role of CHWs as liaisons or a bridge between health and social services is really, they're probably one of their key roles, the liaisons between health and social services and their communities. I call them the bridges over troubled waters. They work with individuals, that probably dates me, but they work with both individuals and groups. They meet with patients and community members where they are, and they address the whole person, whole health, and the entire family. You're going to hear a lot about that today. They address unmet social and or emotional needs, as well as social drivers of health, such as housing, early childhood development, and neighborhood conditions. You know, one of the themes of our presentation today is the power of community health workers. And I'm going to tell a very quick story. I worked in Kentucky for 3 years with the State Refugee Resettlement Agency. And I led 2 pilot programs for CHWs with an FQHC in our region in the Louisville area. And they hired an amazing Congolese woman who was a pastor at her church and beloved in her entire community. And the first week she went out to meet with 2 patients who were pregnant. her program, her pilot was focusing on prenatal care for Congolese women. And when I called her a week later to see how it was going, she said to me she had met 3 other pregnant Congolese women who did not have a primary care provider, and she brought them into the clinic. It just is one example of the power of community health workers working in shared locations and through partnerships between community and healthcare organizations. Next slide, please. So I'm not going to go through all of this, but there is a long history of CHWs in the US as natural healers starting back in the 60s. Especially in African-American communities in the South, and also with our tribal communities in the United States. I want to say that the Department of Labor in 2010 created CHWs as its own classification. The Affordable Care Act recognized CHWs as health professionals in 2010. And then even the American Rescue Plan, which is not on this slide, in 2020-21 allocated $250 million to aid community-based organizations and public health departments to hire CHWs for COVID-19 vaccination efforts. An additional $3 billion to boost municipal health departments to hire and retain CHWs. So I call what's happening with CHWs not only in Vermont, but across the country as a movement. And I'm optimistic that this movement has taken hold in Vermont, and we'll discuss that in just a minute. Next slide, please. So CHWs are a workforce for change. They're a workforce of change because they have the power to transform communities, to support their health and their quality of life. I call them social first responders. A friend of mine in New York actually coined that term, that have unique skills and experience to integrate social care into healthcare delivery and to reduce inequities. You can see from this diagram that I created that as valuable members of the healthcare and public health workforce, they engage in social, medical, and public health systems. And that's what makes them so unique. Engaging them, building support for this profession, and maximizing their unique and versatile roles in these various but interconnected workforces fosters integration of the health and social service systems. And I also want to add in there the behavioral health systems as well. So they are a unique, versatile, and cross-sectoral workforce that's proven, and they address the growing U.S. public health worker shortages in the country. They improve pandemic readiness, especially at the community level, reduce cost and disease by prioritizing the social drivers of health, and they strengthen community resilience and investment, as well as achieving racial and health equity for marginalized communities. Next slide, please. So we are at a pivotal moment, I believe, in our state and in our country in grappling with persistent inequities in healthcare that require new approaches to build a more just and equitable society. And I love this slide from ASTO because I believe it depicts where we are in Vermont and where some of us may be in other states. That in the past and probably up until COVID, we had an awareness of the value of community-based health workforces. And obviously TUDA was way ahead of the scene in this awareness of this workforce. Plus, combined with the opportunity to hire in emergency response and recovery efforts, that's been the focus probably the last 20 or 30 years across the country in many states, not all states. But now we're looking to formalize the CHW workforce, and that through a number of strategies in a number of ways. And I'll go through that in a minute. Next slide, please. So through a project, through a major grant, you've heard a lot about the CDC funding for health disparities, COVID disparities. We received a $500,000 grant through May of 2023, which may be extended, to develop a CHW network. So we are working in collaboration with the Vermont Department of Health and others. to advance this profession in a number of ways. Next slide, please. So the central question which underlies the skip that slide, next slide, please. The central question which underlies the foundation of our work in Vermont is how do we best prepare and support a workforce? This is a growing and essential workforce to address the social needs of populations as a component, just one component of healthcare delivery. How do we do that? Well, we are starting in Vermont by creating a statewide network, which is an ever-evolving mechanism to ensure that the CHW voice, both individual voices and collective voice, is represented and centered in all aspects of workforce development. And that CHWs are a unified workforce. In Vermont, they are a pretty fragmented workforce. I believe we have over 40 job titles of under the umbrella of CHWs in Vermont. And for our size of our state, that's a pretty fragmented workforce. But we are working to unite them and also with allies. We want to establish and preserve their professional identity by uniting them. Next slide, please. So why build a CHW network? I'm going to go through these very quickly because I want to get to our other guest speakers. And what do we mean by a CHW network? As I mentioned, we want to unify CHWs, allies, champions, and other stakeholders. And we have started to do that in Vermont, and we're very excited of the efforts that we've made and the success we've had in just about 6 months' time. We want a CHW network will connect CHWs to each other, as I mentioned, and we want to create a network that can support and empower CHWs. A network can obviously lead into network organizations, such as at the top there, a statewide CHW member-led organization that allows CHWs to lead or co-lead that organization. So that mission and activities could include membership, networking, policy and advocacy, and workforce development. We want to expand the healthcare infrastructure with CHW workforce beyond pandemics. And that is what I think the greatest lesson revelation has been in the Biden administration and also in the last few years, is that we need CHWs as a workforce to address these ongoing endemics that we continue, these persistent problems, disparities that we experience. Including chronic disease, different chronic diseases, obesity, mental health and substance abuse, and all the others that we've talked about today. And finally, we want to advance a more diverse, skilled, and sustainable CHW workforce. So how have we done that? Next slide. How have we done that? And again, I don't have time to report on our full project in this session. I hope we'll have opportunities to do that with all of you at another time. But we have been, since mid-February, we've identified over 200 CHWs statewide, about 200 CHWs statewide, to learn about their work and interests in development. There was no cookbook for this project. We started in the grassroots. We worked with community health teams and different community-based organizations where we knew refugee, and by the way, refugee, migrant, and immigrant organizations in Vermont, where we knew there were cultural brokers and others performing this work, but maybe didn't have the title of community health workers. We've been educating and communicating with employers and prospective employers interested in the workforce, assessing this landscape in Vermont, as well as employer readiness. We organized 3 regional meetings which united CHWs and employers. These were in-person meetings for the first time. Nearly 70 people in 3 parts of Vermont gathered in person to discuss this profession and the work that they are doing. And finally, in our project, we want to encourage investments for the statewide CHW workforce development initiatives. Next slide, please. So we have been leading these conversations across the state about workforce needs and trainings, voluntary credentialing, and the role of CHWs in performing current services and their future work. And as you can see here, We have met with over 200 people, as I've mentioned, and I'm talking about very lengthy listening. It's almost like listening tours, in-person conversations, hospitals, clinics, SASH coordinators and allies, workforce development organizations, housing organizations, free clinics, pediatric practices, community action agencies, our Blueprint community health teams and program managers, as well as LGBT organizations. We're in the process of formulating a CHW alliance statewide to provide guidance and recommendations on CHW core education and training efforts. In Vermont, we currently do not have a standardized core training program. Part of our grant is going to go in the spring to offer cohorts, 1 to 3 cohorts of 10 to 15 people, pilot core training programs for the very first time in Vermont. It's also critical that we support the organizations where CHWs are employed. They need support as well for a variety of reasons, mainly to support community health workers professionally as well as personally. We have set aside another part of our funding, of our $500,000, to train CHW employers and organizations on everything from how to hire a CHW to how to integrate them effectively into team-based care. Next slide, please. So what we've learned so far, and this is not the totality of our learning, but I did want to highlight a couple of them. Vermont has strong local and regional enthusiasm for launching a CHW network, and we are doing that work now. In collaboration with others, we are helping build CHW organizational capacity. This movement can benefit from grassroots organizational involvement, which is, by the way, the approach that we have used, that community health workers use. We have adopted that approach in developing trusted relationships with our partner organizations. Finally, there are significant capacity challenges for public health care and in public health and the social care workforces, and the community health workers complement the work of those other social care workers. If you're not a CHW, partner with CHWs to build the profession, but also to achieve health equity. And with that, I am going to, next slide, please. Next slide. Now we're going to I'm going to take about a minute or two to highlight the community. Sorry, but back up one slide, please. The community health worker models, and I'm going to leave these to our next two speakers to discuss the ones that they have employed in their programs. But I wanted to highlight that in 2011, the Department of Health and Human Services outlined key community health worker program models, and they vary, as you can see on the screen, based on the services provided, the needs of patients and community members they serve, and the goals of the health program, among other factors. I'm sorry? Okay. So these models can be adapted to meet community needs. So there isn't a one size fits all. In fact, for rural areas in particular, components from one model can be adapted to another program model to address community needs. And in the program that I'm going to present at the end of this presentation as a surrogate for Dr. Andrea Green at the University of Vermont, she's actually identified 4 interlocking models that they've employed in their community health worker program. Next slide, please. And coming up next, I'm pleased to introduce or to reintroduce Dr. Ruth Berggren, who will speak about her program that she has developed and has tremendous information and research on the impact of community health workers in health literacy. Thank you.
Thanks a lot. Thank you so much. I'm going to jump right in and bring up my slides. And somebody tell me if you are seeing my slides.
Yes.
I'm going to the slideshow. Okay. So I'm actually speaking to you from San Antonio, Texas. I get to divide my time between 2 extremes of our country, climate-wise and all sorts of ways. My learning objective is to describe health literacy as a tool to advance COVID-19 related health equity in San Antonio, Texas. And I'm going to talk about how community health workers are facilitating a multimodal, interprofessional health communication intervention. My disclosure is that our work is being funded by the Office of Minority Health. And I want to start by acknowledging the very different demographic context of San Antonio from the Northeast Kingdom, where I sometimes hear y'all referring to yourselves. I love y'all. It's the most inclusive pronoun. It's the only part of Texas vernacular that I think I have. But San Antonio is a majority minority city with 64.5% identifying as non-white Hispanics. We have 18% living below the poverty level, large numbers of uninsured. Y'all, we have 283 uninsured residents in San Antonio. Lots of our hospital-based safety net hospital patients are uninsured. They need assistance by translators, and a large number of undocumented population. And we've resettled over 10,000 international refugees since 2010. Enormous numbers of migrants are coming through the city now. All of this is to say that we have a unique demographic context in which all of this work with CHWs is playing out. So let's start with our working definition of organizational health literacy. Health literacy is not literacy. We're not teaching people how to read, and we're not laying this responsibility on the people that we're trying to serve. We're laying the responsibility for health literacy on the organizations that are delivering services. So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use both health information and health services to inform health-related decisions and actions for themselves and others. And this is straight from U.S. Healthy People 2030. I know this is a very savvy audience and you're very familiar, but I just want you to recall this construct of this concept of our multiple levels of our healthcare system, and just think about those numerous models that our colleague Katina Cummings just put up about what community health workers may be doing, and recognize that community health workers actually can be working at a variety of different levels. And perhaps the most common one people think of is within that yellow layer of the onion, where they're interacting with the patients and their care professionals and their families. Our work has much more a focus on the next layer of the onion, the organizational level, which encompasses the infrastructure, resources, hospitals, and clinics. But also, I would argue, as the work progresses, will be in the outer layer of the onion and very important. We're utilizing a convergence strategy. So the idea is we're intervening with health literacy as our tool at multiple levels of that onion. And we hope thereby to influence both clinician motivation and patient motivation to improve the communication and understanding and get real health literacy, which is people doing what they need to do when they need to do it to attain the best level of health that they can in their environment. Here's Bexar County. San Antonio is most of Bexar County. It's showing you in darker red the places that have been hardest hit by COVID. This is an early on in the pandemic snapshot. What's remarkable about this is that it actually replicates the redlining of San Antonio from the 1930s. West San Antonio is poor and Latino, and many people with limited English proficiency. South San Antonio is very poor. East San Antonio has a higher proportion of people that are African American. We have low levels of African American population here, but they tend to be segregated on the east side. So remember that distribution of coloring there from this image when you go to the next one. And this is a COVID impact map that looks at vaccination. So this is back from June 2021. Light green are zip codes within San Antonio that had less than 25% vaccinated. And the darker the green, the higher the rate of vaccination 18 months ago or so. So we had an opportunity to go in with the city of San Antonio for some federal funding. And we were able to get this grant. It was a $4 million grant that was divided between UTSA and UT Health. And we are advancing health literacy to enhance equitable community responses to COVID-19 in these 22 red outlined zip codes that you see here, which comprise in total a big population. It's almost 600,000 people that we're supposed to go after and improve vaccination rates and lift health literacy. We have 6 key initiatives. There are opportunities for CHWs, or promotores, as we call them here, in all of these levels. The most significant areas of their engagement where we rely on them the most heavily are in the community health club trainings, and I'll explain a little bit about what a community health club is, ambassador trainings, where we're going into high schools and identifying student leaders who want to be ambassadors about COVID and health for their communities. We have 2 parallel echoes, which I'm sure you're familiar with, so I won't read the definition. One is for clinical providers, and the other one is in parallel for CHWs, but we always welcome CHWs into the clinical provider echo as well. We have seed grants projects. We have a very exciting health literacy pledge program where non-health delivering organizations, social service organizations, are in a learning collaborative to learn about health literacy. And we have CHWs there too. I'm going to take a deeper dive into the community health club trainings and talk to you about the story of one particular CHW that we're working with. This is just to say we're getting a lot of local attention from media who are really cheering us on as we work hard to improve health equity. This was a piece about how we got 10 churches, community centers, and housing programs to get together and take this pledge to be part of a learning collaborative. So before we get to the CHW story, this is the panoply of activities that our group has been engaged in. That's another way of categorizing our activities within those 6 key initiatives. The exciting part for us is that, you know, there's 600,000 people in our area, but we've directly touched close to 10,000. You know, we believe that every person we touch is impacting others, especially because a lot of these people that we're impacting through these activities are people like healthcare providers or health professional students who are going to be interacting with patients. These are our 5 key messages on COVID vaccines that illustrate the principle of plain language, which is one of the key tenets of health literacy. Won't go over them all here, but you see there's my team, and Dr. Jason Rosenfeld and Mia Vento are key players. I'm not the only person doing this work. I want to acknowledge them here. They're standing in front of a sign that's got the same key messages about COVID vaccines in Spanish. This was at a food bank distribution area where we were going to come back the following week and give COVID vaccines. I won't reiterate this. You all know that there's a huge need for trusted messengers, right? So now I'm going to tell you the story of Fuerza Unida, which is an organization with whom we're working and where one CHW has really been able to make a difference. And Fuerza Unida started in 1990 when Levi Strauss closed down a couple of clothing factories, basically, and suddenly severed the employment of over 1,000 workers, most of whom were women of color in San Antonio. So they suddenly had no job and no severance pay. And so they banded together and created an organization to fight for their rights, and they're called Fuerza Unida. And their mission is to empower women workers, especially women workers of color and their families, to achieve justice. So this guy here, Joaquin Abrego, with whom I've been privileged to work now for a couple of years, actually is deeply connected to Fuerza Unida through his mother. His mother and father were both community organizers and very active in the Fuerza Unida activities. He hadn't been there, had not connected back in the West Side neighborhood for a couple of years, but he showed up and got an invitation to come back to an event that Fuerza Unida was holding. And the Fuerza Unida said, hey, bring your mom and dad, would you? We'd love to see them. So the next week, Joaquin shows up with his mother and father, and they were met like visiting royalty because everybody remembered the role that the Abrego family had played in getting Fuerza Unida organized. And they were celebrating the presence of these community organizers. And then they said to Joaquin, so what are you doing, Joaquin? And at this moment now, Joaquin says, well, I've become a community health worker and I'm working with UT Health, and we're working on stuff related to COVID and helping people understand what they need to do to be healthy. And then he got the invitation, and the invitation was, well, we need the vaccine, and we would like to be able to talk to people about it. So that caused Joaquin to come back to his home hub team. We showed up with people who could talk and answer questions in a health literate manner that was approachable and reliable. And we had this invitation, and we came back and did a vaccine clinic right in the place where Fuerza Unida, they still have seamstresses, they're still sewing, and they have their own business enterprise. That then led to the creation of a community health club with youth. And in the community health club, there is a lot of principles of adult participatory education. There are facilitated club meetings where people come, one, because they want to have a good time and see their peers, but two, they're going to learn something, and three, they're going to go put something into practice. And I'll show you a couple pictures of that in a minute, but here's some key things that I think are so germane to what we're here to talk about. What does Joaquin teach us about what he's learned in getting in there with these messages? First, he says, not everybody's going to take the bite. People have to want to walk alongside you. Our community is armed up and on the defensive. And he says, when you walk in as an unknown, which he was not, but when you walk in as an unknown, they're immediately suspicious. Who are you? What do you want? And of course, how much is it going to cost? And he said, this is a direct quote, it's like everybody has their hand on a gun. And unfortunately, that could be actually true in San Antonio. And he says, I have to get people to take off their armor. That's what he needs to do. You need to build an authentic community relationship before you even reveal your affiliation with an institution or outside system. And that's really what he has done in this interaction and with multiple others. So here's a little teeny snapshot of what the youth-based community health club looked like. First of all, there were about 16 members in this club. It was facilitated by Joaquin, who has special training and a manual that has modules and learning objectives and fun activities for each of the modules. There are about 5 or 6 people from Fuerza Unida, and the rest of them were youth ranging from 9th graders to first year of college. They had 15 sequential meetings, and Joaquin led the facilitated club curriculum. He's not a teacher. He's not teaching down a power grading. He's facilitating, drawing messages, key messages out from the learning group. I've listed some of their activities there, but here's something that's really important. Clubs work when you can create a sense of affiliation and a sense of it's very desirable to be in this club. Why are those people over there having a good time? I want to go be like them. I want to be in that club. Then there needs to be some public recognition. So here they are with their graduation cake. At the end of their 15 sessions, it says, Felicidades, jóvenes. And at the graduation ceremony, there was a lot going on. There was public recognition of these people. There was knowledge sharing. So some of the messages that they had gotten, they're sharing with others. Their community identity was being reinforced, and vaccine messages were being shared and other health messages like, how do we keep ourselves healthy so we're not vulnerable to bad outcomes from COVID-19? Like what are the healthy foods we need to eat? So I gave you an image of the food they were serving at their graduation ceremony, which was healthy. And then finally, this lower right-hand corner, and there was a woman who represents organized religion. She's a faith pastor, and she actually had a blessing for each one of these youth who came. I think this snapshot kind of says a lot. It's intergenerational communication. You've got the blue hair. You've got the sense of people are doing something that's special and it's being celebrated. So our Health Confianza milestones, we're piling up a lot of them. I don't want to bore you with all of these, but focusing on CHWs. 40 community health workers and community leaders have been trained. They've started 9 clubs, 7 have been sustained. We've had hundreds of people participate in our ECHO series, and we're doing 2.0 right now, second iteration. We've got 10 organizations in our pledge program, and they're all looking at their health literacy of their organizations and trying to improve it with help with one another. And we've built really strong partnerships. We would never, look at me, I would never be able to sit here in my UT office and create an authentic connection with Fuerza Unida were it not for Joaquin, who has that authentic connection. So what an amazing partnership. So what have we done? Do we have outcomes? Yes, we have some outcomes. Vaccinations in our target zip codes are increasing. We don't have 100% vaccination, but boy, we have a whole lot better than we did when we started. So 50 to 75% are reporting being fully vaccinated. And since this was funded by the Office of Minority Health, and we're supposed to be repairing inequities, what is going on as we look at by race? And so you see that we're increasing vaccination rates across whites and Hispanics and non-Hispanic Blacks. And we still have a way to go, but going from 30% to 43% is a bigger deal than going from 65 to 79%. And we, of course, cannot attribute all those numbers to our efforts alone, because we're part of that onion layered, multi-tiered healthcare system. So this is really all I have time for. I'd love to unpack it all for you, but I think I'll stop now. There's my contact information, and I'd be happy to answer any questions.
All right. So I think I'm going to steal the screen from you, Dr. Bergeron, and present my presentation, and hopefully we'll have a minute or two at the end of that. Okay. Are you all seeing my presentation screen? Okay, awesome. Well, I'm so excited to be here with you all today to talk about our community health worker program at Dartmouth Health. The first thing I wanted to mention is that I'm going to be discussing a lot of work done by a lot of really talented and skilled and passionate and knowledgeable people. So I'm just excited to be able to be here and share some of that with you today. This journey, the journey that our program has taken has not necessarily been linear, and we have grown and developed and really learned what our health system needed from community health workers, and more importantly, what our community health workers needed from the health system in order to support our patients and really help them access services and improve health equity for these folks. So our program, the origins of this work at Dartmouth Health really started in the emergency department. We intended to work with people who were utilizing the ED because it was their only way to access medical care or other supports, or the only way that they knew. The community health workers were very successful in meeting these goals at the time, and were able to connect patients to primary care. So we saw this list of folks who were repeatedly using the emergency department decrease and decrease and decrease until those folks were connected to primary care. And we said, well, we need to keep these resources, our community health workers, with these folks, because they've just been doing such a great job getting them connected. We need to keep that good work happening. So we sort of naturally transitioned to the community health workers to the primary care department. And at the time, community health workers, we didn't have a lot of them in our health system. I think that we had 2 at the time, but a lot has happened in the years since we first stood up that program in the emergency department. I'm sure a lot of you, or many of you, are familiar with the IDN funding that came into the state, which really helped to expand those services in order to respond to social determinants of health screening that we were doing. And unfortunately, the IDN funding ended. And for a lot of folks, I'm sure that meant that those funding streams, that's one of the hardships funding for community health workers. We were very lucky that we were able to maintain the positions in our primary care settings, and still grow our program, and we're able to show that the IDN project was successful and that we needed to really continue this. Additionally, other people across our organization started to recognize the importance of this work and began hiring their own staff to work with their patients on non-clinical determinants of health. So today we have, you'll see the list there, we have folks in Lebanon in our primary care department, but also in some specialty clinics, and then community health workers across primary care clinics in the southern region as well, and at our system members sites as well. So I wanted to share this with you. We're currently engaging in a system-wide project to really align the work and share best practices of our community health workers. I will talk about that a little bit later on, but this is the result, or these statements are the results of one of the exercises that we engaged in. I thought it did a really good job of describing what the community health worker's role is within the clinical care team and working with patients. So I'm not going to read that to you, but I did highlight a couple of words that I thought were important. So goal-oriented support, collaborating with you and other members of the care team, collaborating with the patient, addressing barriers preventing equitable access to supports, and lastly, making connections. Making connections between with the patient, between the community health worker. We heard a lot about how that trust relationship is so important, and Dr. Bergman brought up a great point. That health systems sometimes do have distrust associated with them. So our community health workers really do have to work to build that trust and show that they can be a person that is a reliable person that can help meet these needs and help the patient access support. So this is another, to relate back to the CHW models that Katina described, here are some of the key actionables that our community health workers engage in. Based on this, I would say that we fit most closely into that care coordinator model, but also the member of care delivery team model, as some of our community health workers have gone through different trainings that would allow them to work with patients on chronic disease goals. For example, we had a cohort of community health workers that went through a training where they learned about hypertension and the social determinants of hypertension. And they also learned how to take blood pressures so that they could work with the care teams to help monitor for hypertension. And that's something that I think we're really excited to build further as a health system and really lean into, to see how this group of people, with their skills and this unique qualities, can really help to facilitate some of those health improvements as well. I'm being cognizant of the time, so I apologize if I'm going a little bit quickly through this. So the first thing that I want to talk about is referrals. So as a health system, how are our community health workers getting referrals? How are providers identifying patient needs and making those connections to our community health workers? So most of our referrals come directly from clinical staff, having conversations with patients and learning of these social determinants of health that may be impacting ability to equitably access healthcare and equitably access resources in the community. But I do want to note that any staff can make a referral to the community health worker. This is important to note because the CHW is a clinic resource, and that's important because everybody can play a part in helping to make that connection and in helping our patients. So one example of this would be for a patient going to the exit secretary and making a comment that they're having a hard time getting to their appointment or not being able to schedule their next appointment because of transportation issues. A secretary can then make the referral to the embedded community health worker within their department. That CHW has relationships with the staff and also the providers. They can make that connection to the CHW for the patient, and that CHW can then work on meeting that transportation goal. But additionally, in conversations, the CHW may learn of other needs that this patient has, maybe related to the lack of transportation, maybe unrelated to the lack of transportation. But for example, they might learn that the patient has food insecurity and then can work with them to help make connections to community supports for food insecurity. Or ideally, if the patient doesn't know where their next meal is going to come from, the CHW has resources in the clinic that they can actually connect patients with. For example, we have food boxes. So the patient can leave with a meal for the night to make sure that they're fed, which is most important. All of these interactions, communication is super important as well for the care team. So all of these interactions are documented within the patient's chart. So our community health workers have access to the electronic medical record. But this information is super important, and it gives the provider a layer of insight to the patient's lives and the situations that affect their ability to reach the optimal health and well-being that they might want to reach for themselves. All right, so as I mentioned, the screener is one of our primary referral mechanisms. So I wanted to share just a little bit of data of what we see at the health system in regard to social determinants of health screening. Most of our referrals for unmet social needs come in are related to financial needs or food insecurity. But we also have a number of referrals come in for housing or shelter needs, domestic violence. And I wanted to point out social isolation as well. That is one that we've seen a huge rise in and is of particular importance with COVID-19 and how that can be isolating. And our community health workers can really be experts in, they're experts in connection, both to the community, but from people connections as well. And that's the first step in addressing social isolation, is making those connections and then connecting to other long-term supports and whatever really the patient needs to feel like their loneliness is decreasing and their isolation is decreasing. So we received a referral, maybe from the screener or from a provider. How do we actually structure the work to measure success? So I'm not going to delve into this too much because I see the time there, but we actually do use the Pathways Community Hub model that was created by Mark and Sarah Redding. What I really like about this model, so over on the side, I listed the key components of it. Really, it's identifying the need, partnering with the patient to connect to resources, monitoring those connections and being a partner in those connections, and then figuring out how to maintain access to that resource. So that maintenance step or the completion step, for example, here I have a financial assistance pathway. That completion step is what we use to measure success. And what I mean by success is a measure that we have actually reduced the risks associated, or the risk for negative health outcome associated with that need going unmet. So that is how we are able to sort of measure if our interactions with the patients are having impact, by seeing if we can meet that completion step there. These are the pathways initiated. You'll notice, the only thing I really wanted to point out here is that you'll notice that the pathways initiated. So the goals that our community health workers are starting with patients, and are patient identified goals. So just because the screener says that there's an unmet financial need, or the provider comes and says this is a transportation need, that does not necessarily mean that is what our community health workers are going to work with the patient on. The patient goals really need to be driven by the patient, because that's how you have most success, right? Like, the patient wants to work on what they want to work on, and in that time you are building trust, building connections, building rapport, and also engaging in motivational interviewing techniques to ultimately be able to build those relationships and hopefully work on other things down the road that might be more sensitive, that the patient didn't want to share with our community health workers immediately. And through that, really facilitating the connections to have some impactful results for the patient. So what are the results that we're seeing, and how do we measure those results? So this chart represents at any point in time. So the green bar shows the numbers of clients enrolled with community health workers during a 12-month time period ending in that month. So they're not necessarily enrolled with the community health worker for that entire period, but anyone who was active during that 12 months is counted within that green bar there. So the lines are what are really interesting here. These lines measure the successful completion step within the pathway being marked. So that means that, for example, it's a food insecurity pathway. That means that that patient has had secure access to food for X number of months before the community health worker closes that food need. And that shows us that the patient knows how to access food. They feel that they have enough food, all of those things. So this teal bar line at the top shows that we were able to, for 60% of the patients with a closed pathway, we were able to meet at least one of the needs that they identified. And then for 53% of the patients, all needs were resolved. So it's a little bit deceiving because some patients might only have one need, so that's not reflected there. But you can see that we're relatively successful in helping patients meet at least 50 to 60% of their unmet social needs. And the needs that go unmet could be unmet for a number of reasons, such as a patient has, we have not been able to connect with a patient, or they've moved away from the area, things like that. So as I mentioned, we are engaging in a system-wide project. I think I'm gonna skip this slide, guys, because I really just want to show you this. I think we're gonna get kicked out here. So I want to end with this note. We went and surveyed providers about the work that our community health workers are doing and how they value it. And some of these messages here just warm my heart. These folks are miracle workers. They find a way to overcome barriers to health and well-being. Funding CHWs is the best value dollar for dollar in healthcare spending today. And I think that this very clearly shows that our providers really value this, having the community health workers as a resource on their teams and having them be an integrated part into the care team. And I think that it also shows that our patients value that as well. And working together, we can really achieve a greater impact on patients' health by addressing those social needs as well as clinical needs. So I'll go ahead and stop sharing, if I can figure that out. And I don't know if we have time for the next part of this presentation, but thank you very much for listening to me today talk about our program.